Yes? And this kind of variable or this kind of test. In this situation, a decision must be made in establishing a cutoff point or cutoff level above which a test result is considered positive and below which a result is considered negative. For example, blood sugar is a continuous variable, yes, and in this situation you should establish a cutoff point to distinguish healthy and unhealthy people based on evidence. For example, what's the cut point of FPS? 126. Yes? Above 126, we consider the result is positive for diabetic person, and below this result or below 126, we consider the result is considered negative about diabetes. Yes? So when we deal with or when we use a continuous variable, we have to establish a cutoff point to distinguish or to dichotomous our variable. For example, in this example, when we establish a cutoff point in this value or in this point, we can identify 5 people as positive or 5 people who has diabetes as positive, and 50 people who have a disease or a specific disease or diabetes considered negative. Yes? And what is sensitivity?
Predictive disease.
5 divided by 12. It means 25%. And what is specificity?
8 divided by 2.
90%. Yes? So when we have a dichotomous variable, you should establish a cutoff point.
Bro, you're a hacker. You're a hacker.
I know. Thanks.
How do you do that?
This is me, bro.
When we have a dichotomous variable, you have to establish a cutoff point. For example, in this scenario, we establish this cutoff point, yes, as positive or negative, above which we consider it positive, and below which we consider it negative. Based on this cutoff point, sensitivity and specificity of our test is 25% and 90% respectively. But imagine that we consider this point as cutoff point. What happened? In reality, blue means diabetes and red means non-diabetes. What is sensitivity and specificity? Okay, when we change the cutoff point, sensitivity and specificity would change, yes, or will be changed. So sometimes, as I said in previous session, sometimes sensitivity is more important than specificity, and sometimes specificity is more important than sensitivity. And establishing cut point depends on our objective. Sometimes we try to detect all patient or all disease person, and sometimes we try to identify healthy people correctly. in this situation, specificity is more important. For example, when we want to use a test for diagnosis of HIV, it's important to correctly identify healthy people. Yes, in this situation, specificity is more important than sensitivity, because being positive or being false positive, yes, it's very, very dangerous in this situation, because it can create big problem for patients. Okay. Asif Amara, Ibrahim Abbas, Osama Qasim, Ashraf Mahwash. Is like in diseases like HIV, false positive or reducing false positive is very, very important. Why? Because false positive can create some problem for patient or for positive person. For example, as you see, the anxiety and worry induced in persons who have been told that they have tested positive is or how many negative effects on your mentality or your physical health of people. So in diseases or in complications like HIV, specificity should be high, because when specificity is high, false positive is low. So in this situation, you try to increase the specificity. But sometimes, for example, you want to diagnose some disorders like hypertension. Yes, in hypertension in complications like hypertension, you try to have a test with high sensitivity and high specificity, or high sensitivity, because having hypertension cannot create a big problem for people, or having a mental, for example, effects on your patient or their patient. Yes? So in this situation, you prefer to have a test with high specificity in HIV. But in a situation like hypertension, it would be better to have a high sensitivity and high specificity, or both of them. Okay. This picture shows the impact of cutoff point on sensitivity and specificity of a test. For example, imagine that you establish cutoff point on 80, yes, and in this situation or in this cut point, the sensitivity and specificity is here. Sensitivity is perfect, yes, sensitivity is perfect, but sensitivity is not perfect, because you choose or you establish a low cut point. It means you can include all patients, or you can diagnose all patients correctly, or all disease person correctly. But imagine that you establish another cutoff points for distinguish between healthy and unhealthy people, or diabetic and non-diabetic person. In this situation, your specificity of test is perfect, but sensitivity is not perfect. Yes? It means there is a trade-off between sensitivity and specificity. If we increase the sensitivity by lowering the cutoff point, we decrease the specificity. If we increase the specificity by rising the cutoff point, we decrease the sensitivity. It's clear, yes? It's a trade-off between sensitivity and specificity. But the best scenario, best approach is to have a test with high sensitivity and high specificity. But it's not practical. It's not feasible to have this kind of test. And sometimes we have to choose one of them, sensitivity or specificity. Because a remarkable part of tests are how high sensitivity or high specificity, not both of them at the same time. And which one is more important? It depends on your condition or your disease or your outcome. Sometimes, for example, positive, false positive is more important. Sometimes negative, for example, or false negative is more important. It depends on. Okay. So far, we talked about two indices about a screening test, sensitivity and specificity. Right now, I'm going to talk about two others indices, predictive value or positive predictive value and negative predictive value. Please read this slide and give me a summary. It mentions that sometimes we may ask if we screen a population, what proportion of people who have the disease will be correctly identified. Yes? It means sensitivity. Do you agree?
Yes.
Yes. Sensitivity is what proportion of people who have the disease will be correctly identified. But sometimes the question is that if the test results are positive in this patient, what's the probability that this patient has the disease? This is very important in clinical setting and for the clinician. It means sometimes you want to answer this question. Disease, not disease, or test positive and test negative. Sensitivity, what proportion of people who have the disease are diagnosed as positive. But positive predictive value means what proportion of people who have positive test, yes, are truly or correctly positive or truly diseased. It means A divided by
A plus B.
Okay. It means positive predictive value. What does it mean? It means what proportion of people who have positive results, yes, are correctly positive or are correctly diseased. It means positive predictive value. What proportion of patients who the test positive actually have the disease in question. Okay? And negative predictive value means the probability that a person is actually disease free given a negative screening test. It means okay, negative predictive value. The likelihood that a person is actually disease free given a negative screening test. The total number of people that given a negative test is C plus D. Yes? And what proportion of them is correctly negative or correctly free disease? D divided by D plus C. Okay.
I'm so sorry, can you repeat that part?
Okay. Please explain for your friend, one of you. What is the difference between positive predictive value and negative predictive value? Please.
Positive predictive value is the one in which the test is positive, but what is the prediction that he has done? Okay? And the negative predictive value is that the test is negative, but what is the prediction that he does not have done?
Yes.
ऐसा है तो क्यों है?
What proportion of people who have negative results is correctly or free disease? Yes, it's negative predictive value. Positive predictive value means what proportion of people who have positive test are correctly disease. Yes, A divided by A plus B. It's positive predictive value, and negative predictive value means D divided D plus C. Please write this slide, please. It's so important. And the interpretation of these values or these indices is very important, or very important. Sensitivity, specificity, positive predictive value, and negative predictive value. Okay. And based on this example, what is the sensitivity based on this example?
80 divided by 10.
Sensitivity is 80%. And sensitivity is
8 by 9.
100 divided by 9.
800 divided by 9. And what is the positive predictive value and negative predictive value? 45% and 98%. Please interpret this value. What's the meaning of 45%? Please.
It means that 45% of the people who tested positive actually have the disease.
Yes. Or in other words, it's very important. If you have a positive test, the probability or the likelihood that you actually have the disease is 45%. And if you have a negative test
Then
or negative result, the likelihood,
90% chance you don't
Yes.
have the disease.
the chance or the likelihood, it would be better to use likelihood, the probability, that you actually don't have the disease is 98%. Yes? And based on this example, please write these examples because I think it can be useful for you. You can calculate sensitivity, specificity, positive predictive value, and negative predictive value. Okay. An important point. In contrast to sensitivity and specificity, which are generally considered inherently stable for a given diagnostic test, positive diagnostic test, positive predictive value and negative predictive value are highly dependent on two factors. One of them is the prevalence of disease, and another that is a specificity of the test. It means sensitivity and specificity of a test inherently are stable in many populations, in general. For example, the sensitivity and specificity of a specific test, like mammography, considered stable in all populations, general. But predictive value, negative and positive, depend on or depend with the prevalence of disease and a specificity of disease, a specificity of test. Yes, it means, for example, in this situation, the prevalence of disease in two populations is 1% and 5% respectively. Imagine you have two different populations. For example, the prevalence of breast cancer in in Iran and in another country. Yes? The prevalence of disease in Iran, for example, is 1%, and in another country is 5%. Even if you have a specific test and same test with same sensitivity and specificity, positive predictive value can be different among these countries. Yes? And it means when the prevalence of disease is high, we can consider positive predictive value higher. Okay? We use same test among these population or among these countries, but positive predictive value are different between them because the prevalence of disease or interested disease are different among these countries. For example, in Iran, prevalence is 1%, and for example, another country, the prevalence of disease is 5%. Yes? Sensitivity and specificity is same in both of countries, but positive predictive value is different. Why? Because the prevalence is different. It's very important point. It means the relationship between predictive value and disease prevalence shows that the results of any test must be interpreted in the context of the prevalence of the disease in the population from which the subject originates. It depends on disease prevalence. Please write this example and solve them, please. Please justify what is difference between two examples, two scenarios. In this scenario, prevalence is 50%. In this population, prevalence is 20%. But sensitivity and specificity are same among this population. Please calculate positive predictive value. Sensitivity and specificity are same, but positive predictive value are different because the prevalence is different between two populations. Finish? And another factor that affects on positive predictive value or predictive value is specificity. The prevalence of the study is same between two populations. Yes, it's 20%. Sensitivity is 50% and specificity is 50%. In this scenario, positive predictive value is 20%. But in this scenario, in other scenario, prevalence is 20%, sensitivity is 90%, and specificity is 50%. Is the both tests have same specificity. But as you see, please calculate the positive predictive value. In this scenario, it's 20%, and in this scenario is 31%. Yes? But imagine that we have another scenario in which prevalence is same, 20%, sensitivity is 50%, same, but specificity is 90%. In this scenario, when we calculate positive predictive value, it's 56%. It means a specificity or changes or changing the specificity can change positive predictive value. Yes? It means both increasing sensitivity and specificity can increase positive predictive value. But the impact of increasing the specificity is higher than increasing the sensitivity. Do you understand it?
Me.
Please give me an example. Please write an example in which and design two scenarios. One of them, sensitivity, for example, is low and specificity is low. But in other scenario, you can please give me a scenario in which both specificity and sensitivity is high. After that, please calculate positive predictive value. Please. You can use this scenario, for example, but please change the value or the number. Please look at the slide, please.
Just wants you to.
In this scenario, yes, the prevalence is 20%. Sensitivity is 50, and specificity is 50. In this scenario, positive predictive value is 20%. In the next scenario, we increase, yes, we have increased the sensitivity of this. Right now is 20%. After this increasing, positive predictive value increased, yes, has increased to 31%. After that, we have changed the specificity of this. Yes. It was 50%, right now it's 90%. When we increase specificity, positive predictive value increase remarkable, yes, or significantly. It shows that a specificity have a greater effect than sensitivity on predictive value. The point is that, the point is here, a specificity have a greater effect than sensitivity on predictive value. Both of them can increase positive predictive value, but the impact of sensitivity is higher because of many reasons. For example, you can see one of these reasons. A change in specificity has a greater effect on predictive value than a comparable change in sensitivity. Because when you change a specificity, a significant part of patient or a significant part of people are negative or undiseased. So you can change, you can have an effect on many people or many patients. So a specificity has a greater effect on predictive value than a comparable change in sensitivity. It's the point. Okay. You're tired, yes?
Yeah.
Do you want to continue talk of tomorrow?
No.
No. Okay. We talked about validity. Validity has two components: sensitivity and specificity. And we discussed two other indices about screening tests, including positive predictive value and negative predictive value. As I said, we consider validity, including sensitivity and specificity, stable over all population, but negative predictive value and positive predictive value depend on many factors. Yes, like the prevalence of disease and specificity. Right now, I'm going to talk about reliability. What does it mean, reliability?
It will
do it again? We can do the test again. And the value should be the same.
What?
We can do the test again.
Yes.
And the value should be also the same.
This means the reliability refers to ability to produce
Consistent results.
same or consistent result or same result being conducted under conditions multiple times. For example, we want to measure your weight or your, for example, yes, your quality of life. The reliability means refers to ability of our test or my test to produce consistent result again and again.
With minimal margin for errors.
Yes. And there are many sources we consider for variation between test results. For example, when we measure your weight and I observe different value, we should consider some reasons for this variation. Yes? At first, intra-subject variation. For example, variation between individual subjects. Imagine that we want to estimate, for example, the average weight of this class. Yes? And a main source of variation is variation within individual subject. For example, right now, your weight is 70 kg, yes? But after dinner or after lunch, your weight can be changed, yes? It's intra-subject variation. For example, you want to measure blood pressure of some people, and you can observe some variation, and a considerable part of these variations is because of or is due to intra-subject variation. Another source of variation is intra-observer variation. For example, your blood pressure are measured or is measured by many interviewers or many people or many physicians, yes, or many nurses, and it can cause some variation. And inter-observer variation, what does it mean? It means variation between those reading the test result. For example, people who want to make a decision on your result. Yes. For example, you gives your physician ask you to take some photo or some CT scan, for example, X-ray photo, and after that, your doctor want to diagnose, yes, make a decision about your disease or about your complication. And it can cause some variation, or it's called inter-observer variation. So we can consider a lot of reasons for not reliability or for variation. Intra-subject variation, for example, when we want to measure blood pressure, it means value obtained in measuring many human characteristics, often vary over time. For example, in the morning, afternoon, at night, your blood pressure can be different. Intra-observer variation, sometimes variation occurs between two observations made by the same observer. For example, a radiologist who read the same group of X-rays at two different times may read one or more of the X-rays differently the second time. It's clear?
Yes.
And inter-observer variation, another important consideration is variation between observers. Okay. One of the one of the indices or indicators to assess reliability is percent agreement. Percent agreement. For example, to calculate the overall percent agreement, imagine that you have a lot of tests or a lot of X-ray, yes, X-ray photo or X-ray picture or radiology test. After that, you give them to two independent persons, two independent experts. For example, two radiologists. Yes, the first radiologist classified X-rays or result of test into 4 categories: abnormal, suspect, doubtful, and normal. At the same time, you give these results or this X-ray to another expert or another radiologist, and he or she categorized or classified these results into 4 categories: abnormal to normal. And right now, you want to calculate percent agreement. For answering this question, at first, you should sum the number of tests or the number of results or the number of X-ray that both of them have same opinion or same comment or same diagnosis. It means A, the number of persons who both of radiologists, yes, classified them into abnormal, yes, plus F, because F refers to the number of persons or the number of patients who are classified by both of radiologists into same category, K and P, divided by total readings or total results. For example, I give you some, for example, test, and I ask you to put them into 3 categories. For example, positive, negative, and unknown. Yes? For example, we have 2 radiologists, and I ask them to categorize some results or some X-ray, for example, examination. Positive, negative, and unknown. Total number is 100, for example, and 25. What is percent agreement? What is percent agreement in this scenario?
75.
Divided by 100. You understand?
Yes.
Why V plus or sum 25, 25, 25?
Because both of them.
Yes, because both of readers or both of radiologists correctly classified them into same category. Yes, or they have a consensus about these cases. It means agreement. Okay, another indicator or another index is kappa. It's kappa. We are not going. I'm not going to talk about this formula and etc. But the name is important. Kappa. Kappa is an important index to assess the reliability of a test. Kappa index. Okay, I think it's enough, but please, I write some sentence on board. Please take a photo because it's very important. I'll send you, I think, 4 files. Yes. Okay. I'll send you a video about errors in epidemiology. On WhatsApp and NAV. I'll send you some file and videos on WhatsApp and Navi, including video about errors in epidemiology, a video about outbreak investigation, plus chapter 12 Gordon's book. It's very important. And a file about population attributable risk, because we talked about population attributable risk fraction, but I'm gonna share with you a file about population attributable fraction. Yes? And finally, a file about multiple tests. And I'll send you this slide today on WhatsApp group. Okay. Our sessions was finished. And I hope please don't hesitate to ask me any question. If you have any question on WhatsApp or email, please write my email. Thank you. please write my email address, and if you want to more example, I can give you some, for example, file.
Serial ده.
Okay, thank you. I'll send you this file.